Hello, everybody. I shall be talking about tips for successful DALK surgery. I have no financial interest to disclose. Deep anterior lamellar keratoplasty, or DALK, refers to a surgical technique where the 90% of host corneal stroma is replaced with donor tissue, leaving behind intact Descemet's membrane and the healthy host endothelium. The major advantage is there is no risk of endothelial rejection. You require to use steroids for a shorter duration, thereby avoiding complications like steroid-induced glaucoma or cataract. You can do much larger diameter graft without the risk of rejection, and you can easily obtain tissues from the eye bank. Indications: virtually any corneal conditions where the endothelium is healthy. Common indications are ectatic disorders like keratoconus, post-LASIK ectasia. You can do it for various corneal scars, stromal dystrophies or degenerations. Can be combined with ocular surface reconstruction and also be used for managing non-responsive corneal infections. When you talk about DALK, there are basically two techniques. One is a technique where you expose the pre-Descemet's layer, referred to as the DDALK or Descemetic DALK. This can be achieved by stromal injection of air, viscoelastic, or fluid. The other one is a manual technique of near Descemet's dissection, or often referred to as PD-DALK or pre-Descemetic DALK. And it can also be intraoperative OCT guided as well. In the pre-op evaluation, you need to do a careful slit lamp biomicroscopy looking at the extent of corneal pathology. If there is a scar, whether the scar goes all the way up to the Descemet's membrane, any evidence of limbal stem cell deficiency or corneal vascularization. And in the diagnostic tests, the most important is the corneal OCT, which can identify any pathology involving the Descemet's membrane. Thereby, you can avoid injecting air. We also need to have some idea about the regional pachymetry. You can do a tomography, also a specular microscopy and slit lamp photography for documentation. Surgical instruments include the suction trifines, various forceps, the air injection cannula, the stromal dissectors, and the corneal scissors. The original technique of big bubble DALK described by Mohammed Anwar involves injection of air into deep stroma using a 27 gauge needle. And you get this appearance of a whitish ring, which expands from the center to the periphery. And this is quite successful. We found that you can achieve the big bubble using this technique in about 65 to 70% of cases. In 2013, Harminder Dua described the pre-Descemet's layer, which is again helped us understand the types of bubble much better. The type 1 bubble is something that starts in the center, has a dense white frothy margin, concentrically expands outward, achieves a diameter of about 8.5 millimeter. The separation here is between the stroma and the pre-Descemet's layer. In contrast, the type 2 bubble has a very fine, sharp, clear margin. It can expand to beyond the 8.5 millimeter diameter. And the separation here is between the pre-Descemet's layer and the Descemet's membrane. A combination of type 1 and type 2 is referred to as the type 3 or the mixed bubble, where the bubble starts off as a type 1 and then breaks away, forming a type 2 bubble. In the surgical planning, as I mentioned, we need to have some idea of the regional pachymetry, which can help us decide the size of the trifine, that means the diameter of the trifine, and also the depth of trifination that you're going to perform. Various trifines, these are trifines with fixed depth, guarded depth trifine from coronate. So they come in 300, 350, or 400. So you can use them and use them as conventional handheld trifines. Centration is an issue though while using these trifines. The common trifines that I use are the Hesburgh-Barron trifine, where each quarter turn moves the blade down to a depth of 60 microns. And this allows a better centration and a nice cut depth all around. If you have access to femtosecond laser, you can use the femtosecond laser to make shaped incisions like top hat or mushroom or zigzag. In certain cases, when you're doing very large diameter DALK, you may use a diamond knife with a preset depth to manually make the trephination cut. Like making these 4 marks, 2 horizontal, 2 vertical for centration rather than just having a central mark. So in this case, which is a case of post-classic ectasia, we have the edge of the flap, which is already marked out. Then we mark the trephination, which is a 9 millimeter mark. And then we apply our section trefine. And the trefine is centered so that it touches all the 4 marks that we made, 2 horizontal, 2 vertical. And then once the trephination is performed, you find that the cut has gone through all the 4 marks, giving you excellent centration. And the advantage of using a suction trefine is you get the same depth of cut all around. I prefer to do an anterior lamellar keratectomy before injecting the air. The advantage is that it allows a deeper placement of the cannula. Because the stromal tissue is debulked, the incidence of stromal emphysema is also reduced. And the final advantage is once the big bubble is formed, you can quickly deflate it rather than wait till the anterior lamellar keratectomy is over. If the apex is very thin, then you do the debulking but avoid exposing the apex. Otherwise, when you inject air, the air will tend to come out anteriorly. With the needle, you can achieve the big bubble, but when you're starting off with the surgery, surgeons tend to place the needle more superficial, ending up with superficial emphysema. And if they venture out too deep, they end up with perforating the posterior layer with the needle. So most surgeons tend to prefer blunt tip cannulas, which has a bottom port for air injection. In addition, I like to use the stromal fixation forceps and the pointed dissector. The stromal fixation forceps holds the residual stroma, stabilizing it. The pointed dissector goes to the base of the trephination and just makes a small track in the stroma into which the air injection cannula is introduced and moved forward. And then as you inject air, you find an initial resistance and a sudden give-way sensation with the initiation of the big bubble. How do you reach the ideal plane? When you're introducing the cannula, you may suddenly feel an ease of resistance as you are advancing the cannula, which tells you that you are in the right plane. You can look at the tip of the cannula against the air bubble in the anterior chamber and look at the dark shadow between the tip of your cannula and the air bubble. If you keep your pupil dilated, again, in the retroillumination, you can look at the wrinkles in the posterior layer or decimus membrane. If you use a diamond knife, you can make a cut depth of about 90-95% before introducing the cannula, so that makes sure that your cannula is at the right depth. If you have intraop OCT, you can use that as a guide to see whether your track is deep enough. Or in certain cases, you can use the femtosecond laser to make the track using OCT guided for the introduction of the cannula. When you inject air, you feel an initial resistance, a give-way sensation, then the bubble expands, and because the aqueous is nowhere to be displaced, you will again find that the resistance starts building up. This is important because once you start feeling the resistance, if you continue to inject air to expand the bubble, the pressure in the bubble may reach a point where it cannot overcome the pressure in the anterior chamber and result in a rupture. So this study also looked at this experimental study looked at the intraocular pressure and the size of the bubble, and they found that if the intraocular pressure is higher, the bubble size tends to be smaller due to the resistance from the intraocular pressure. So based on this, we proposed this theory. This is the animation showing why the bubble ruptures. And the advantage is that we do a 2-stage injection where we inject the initial air to initiate the bubble. And then we do a paracentesis to release some aqueous, which reduces the intraocular pressure and the counter pressure from the aqueous. And now when you enlarge the bubble, you can avoid having that rupture. The case selection, you should avoid air injection in cases of macular dystrophy, very advanced keratoconus, extreme thinning, or if there are any scars involving the decimus membrane. And it is seen here that if you do it in macular dystrophy, you can have abnormal bubble, usually the formation of type 2 bubble or a mixed bubble. Otherwise, you can also have the bubble initiating and then rupturing. How do you identify the bubble? One is the small bubble test as described by Fontana and Parthasati, where you put a small bubble in the anterior chamber and it remains in the periphery if the big bubble is there. The other way to find out is to release aqueous and your periphery becomes soft and the center part where the bubble is still remains firm. This is just to show you the intraop OCT, trying to identify the track before you inject the air. Once you get the bubble, you can also use the intraop OCT to identify the type 1 bubble. You can deflate the bubble using a number 15 blade, but if you apply some viscoelastic on the corneal surface before you deflate it, the escape of air is more controlled and you can avoid perforating the posterior layer. Before you excise the residual stroma, it's important that you mark the site of deflation. Otherwise, once you do off the anterior keratectomy, you might miss out where the site of deflation was. And use blunt tip scissors to cut the residual stroma into 4 segments and then remove it carefully. It's important to look out for peripheral adhesions between the residual stroma and the underlying predecimus layer. If you're not very careful, you can end up creating a perforation during this maneuver. The donor graft sizing for ectatic disorders is usually the same size, but if you are using it for other indications, you can oversize it by 0.25 to 0.5 millimeters. The decimus membrane from the donor tissue is usually peeled off either using a forceps or you can use a Merocell sponge to scrape it off. Suturing is the same as what you do in penetrating keratoplasty. In DALK, we take the bites about 85 to 90% depth and about 0.75 to 1 millimeter, slightly longer on the host side, and keep the chamber formed so that you have a normal intraocular pressure when the sutures are being performed. This is a post-operative outcome showing you a nice clear graft with very good cell counts. Femtosecond laser, as I mentioned earlier, gives you the ability to create shaped incisions which have a larger surface area. So you have more strength of the graft source junction. And also because the donor and the host position is pretty good, you can have reduced astigmatism as well. So this is a case of a patient who has intracorneal rings where we had planned a femtosecond laser DALK. So the anterior diameter is larger, the posterior diameter is smaller. This is a mushroom-shaped incision. The rings are removed, and then we go ahead and we inject air to create the big bubble. The diameter of the big bubble basically has to be large enough to cover the posterior cut diameter. And the donor is also prepared in the same way. With femtosecond laser, you don't need to really oversize. We prefer to use the same size, and this is then secured in position. That's the post-operative outcome, showing you a nice alignment of the donor and the host. Here, showing you the visco bubble, where you introduce a cannula into the deep stroma, and as you inject the cohesive viscoelastic, you get the similar formation of a visco bubble. You can see the air in the anterior chamber getting displaced to the periphery, and you can deflate the visco bubble, and then rest of the steps are quite similar. So if you have a failed air injection, you can attempt to inject viscoelastic along the same track to achieve a visco bubble. After multiple attempts, if you fail to achieve a big bubble, then you can resort to a manual technique. So we go to the periphery, create a small pocket, and this is a stromal pocket forceps that I designed, which are blunt tipped. You can use that to create a stromal pocket in the periphery along the trephination. And this is done both clockwise and counterclockwise. And you can see that we have done this pocket. And thereafter, you can do something like the Malbrand's peeling technique, where you use your left hand with a tooth forceps to retract the stroma, and you find that it separates at the deeper plane. A similar technique is used when you are dealing with advanced keratoconus or scars involving the decimus membrane, where you do not want to use any form of air injection. So this is a stromal dissector that I designed. So you do your trephination, perform the debulking, the initial debulking where about 40 to 50% of the stroma is removed. And thereafter we go make a deep peripheral pocket, and then we use the stromal pocket forceps to create this peripheral pocket along the trephination mark. And then we use our the left hand to try and do the stromal peeling. In the right hand, the dissector basically assists the peeling by breaking the stromal fibers. And we can achieve a pretty uniform, smooth plane using this technique. That's the stromal dissector and the stromal pocket forceps. That's the post-operative outcome, showing you a residual stromal bed of about 30-35 microns and a good visual outcome. So this is a patient who had a high drops with an apical scar where air injection was not advisable. And this is the same case after a manual deep anterior lamellar keratoplasty. This kind of technique can also be involved in cases like this blast trauma where there are multiple foreign bodies. You can do a manual DALK, or a case with a penetrating trauma. There is an irregular scar where manual DALK along with the 4-flange fixation of IOL was performed with good visual outcome. That's the site of perforation after the manual DALK. You can see that the stromal bed, although it's thick at about 150 microns, but it is pretty smooth. DALK can also be performed using gamma irradiated corneal lenticules. This paper we published last year in BMJ. We use this tissue for macular dystrophy and keratoconus. And the tissue basically is gamma irradiated, so it's acellular. It's stored in albumin containing medium, and it can be stored at room temperature for a shelf life of 2 years. It handles quite well like a normal donor tissue. You can punch it out and then use it for your surgery. The left side image shows you the post-operative outcome. One of the common complications of DALK is, if you have intraoperative perforation and you, despite giving tamponade, you can get a double anterior chamber. Like in this case, most of these cases can be easily managed by doing a rebubbling. It's important to keep the pupil dilated to avoid having a pupillary block or Ureth-Savalia syndrome. Or intraoperatively, if you have a perforation, you can consider doing an inferior PI so that if you leave behind a large air or gas bubble, you avoid the pupillary block. The type 2 bubble management, this is a nice paper published last year where they looked at the various management. Type 1, in the first technique, they tried to expose the type 2 bubble. The second and third, they basically tried to do manual near decimates dissection. And the outcomes were when you try to expose the type 2 bubble, in almost 75% of the cases, you have to convert to a penetrating keratoplasty. And as opposed to the technique 2 and 3, where the exposure of type 2 bubble was avoided, they did not have any conversion. This is again looking at the visual outcomes of DALK. A lot of large series from single surgeons have shown good outcomes, but when you look at the studies from various registry, like the one from Australia, they found that the DALK outcomes are inferior to penetrating keratoplasty. So this is a nice paper from Moorfields Hospital published in American Journal of Ophthalmology last year, where they looked at a multi-surgeon study, including both experienced surgeons as well as trainees. In about 357 eyes, they found that 77% of the cases had a corrected distance visual acuity of 20/40 or better. The failure rate was only 4%. Perforation rate was high because of the learning curve in about 45% of the eyes. 24% they converted to penetrating keratoplasty, and out of which they had a rejection rate of 19.6%. The conclusion was that even if you have a perforation, you try to do a conservative management without conversion to penetrating keratoplasty, because if you convert to a penetrating keratoplasty, the risk of rejection is quite high. So in conclusion, DALK should be considered as a procedure of choice for corneal diseases with healthy endothelium. Surgical techniques continue to evolve, ensuring greater success of big bubble DALK. Pre-op evaluation and surgical planning is essential to minimize complications. In future, femtosecond laser technology and integrated anterior segment OCT may help improve outcomes in future. Thank you for a patient hearing.